Coming up on the Daily, can doctors in shopping centres fix the NHS? Find out in just a moment. Hi everyone, Neil Patterson back here in the Sky News Daily studio. Do hope you managed just a wee bit of time off yourselves. And like the podcast team, the government is hitting the ground running this new year. The Prime Minister announcing big changes to the health service designed to tackle those well-known problems around waiting times. Currently, there are more than 7 million people awaiting treatment.
If we can get more GPs consulting immediately with specialists, diagnosing even more quickly, then we'll avoid an extra 800,000 unnecessary referrals and appointments every single year. Another game changer, community diagnostic centres. We will open them, more of them, and it'll be 7 days a week, 12 hours a day.
And so, Sir Keir Starmer has promised the best part of 500,000 additional appointments at what are known as community diagnostic centres, little outposts of the NHS, but outside of hospitals. Ashish Joshi is our health correspondent. Ashish, just explain exactly where you are, as it is pretty central to Sir Keir's plans.
Yes, it's going to be one of the key planks in the government's drive to reform the NHS and to make sure that 92% of patients are seen within that 18-week target. And where I'm standing right now is going to be very important in his rollout for these CDCs. A CDC is a community diagnostic centre. Essentially, it's like a mini hospital on your high street. So the one I'm standing in now is in a shopping centre in Wood Green in North London. So just to my right, outside these doors, it's a normal shopping centre. Cafes, restaurants and shops. Once you come through these doors, and there's a waiting area just behind me, there are CT scanners, MRI scanners, blood tests, all sorts of diagnostics taking place here. That's what the government wants to do. Wants to make healthcare accessible to patients in a drive to bring down this 7.5 million strong waiting list, especially the people who are waiting for care the longest. These CDCs will be rolled out across the country. So the plan is to take the pressure off the hospital, take the pressure off the GP, have patients who can walk in here and have their treatment. And the important thing, and this is really important for the government to try and get across to patients, is these centres will be open for 12 hours a day, 7 days a week. So in the words of the government, healthcare working around the patient, not the patient adapting to the timetable of the NHS.
What conditions are going to be treated in these CDCs, community diagnostic centres, rather than in hospitals or by general practitioners?
This morning, I was with a patient, a 75-year-old woman, a lifelong smoker. She packed up smoking at the beginning of December. She needs to have a scan on her lungs to see whether there are any early signs of cancer. Instead of going to her GP writing to a specialist, her specialist trying to find a slot at the CT scanner in her local hospital. Instead, the GP refers her here, given an appointment time. She walks in, it's on the high street. She was seen by the radiographer this morning, had her scan done, and she's walked out. And the whole process took 45 minutes. The idea is to try and pick up lung cancer and other conditions early on, because there are millions of people who are still waiting for simple diagnostic checks. So this keeps the pressure off the hospital. So the hospital will deal with long-term chronic ailments and will still have that door open for emergencies. They don't want to be seeing people with short to mid-term conditions or long-term conditions. That's where centres like this will take up a lot of the pressure and keep these patients away from that hospital. And this will help because the GP is tied up with this service. They can refer people here for a blood test. They don't need appointments. They can come in, they can get their blood test, those results go straight back to the GP. And the process, the healthcare is continuous.
OK, but doesn't this mean that there is going to be something of a tension? Because in the stuff that Sir Keir Starmer has announced today, we're not forgetting about hospitals. We're not removing them from the equation. They still need assistance. Is there not then something of a tension between, plans to keep hospital care ticking over and to remove all of this responsibility from hospitals and place it into these CDCs?
That tension, to some extent, has always existed between hospitals and primary care, because it's about budgets and it's about the number of patients you treat, and essentially that comes down to how much power you have. What the government is trying to do is the hospitals have said year after year after year, every year we deal with this ongoing winter crisis. The government wants patients to be treated in the community. They want the hospitals to do what hospitals are set up to do: chronic long-term conditions, surgical interventions, surgeries, and emergency departments. Everything else should be dealt with in the community. And GPs will tell you that they are already doing a lot of the work that's been outlined, and now we're going to be recognised and paid for it. Will it eat into the hospital budgets? Maybe, because that money has to come from somewhere. So hospitals will take on different roles. They'll expand their elective care capacity. Remember, this is all about bringing down this waiting list. If hospitals are absolutely stacked and they can't have any more patients, they can't deal with any more patients, so what it's doing is it's creating some slack in the system, taking some of the pressure away, bringing the patients away from a hospital setting and letting hospitals deal with that backlog, because that's what the government is pinning everything on, is bringing down the long-term elective care waiting list.
Look, Ashish, we're going to be hearing a lot about elective and non-elective care. Just explain exactly what the difference is between the two.
Mm-hmm. Elective care is care that is planned, is not urgent, and it's not life-threatening. But if you're waiting for a hip or a knee, you could be waiting for a long time in agony. You will be immobile, and the quality of your life is impaired substantially. So elective care is care that is recognised but can be planned for. So that operation or that procedure can be penciled in, put in the diary 2 months down the line, 3 months down the line, 4 months down the line. And that wait has been growing longer and longer. And as that wait grows longer, the patient becomes sicker. Non-elective care, urgent care, is when you've had that stroke or that heart attack or any other life-threatening condition which needs, or cancer, for example, that needs urgent treatment, urgent assessment and urgent treatment. And that can't be planned for. That has to be carried out immediately.
What's it like? I mean, I know you're there to report rather than for treatment, but what is it like to wander past, shoe shop, pharmacy, supermarket, card shop, and then pop into, what looks very much like a hospital waiting room or a GP surgery waiting room?
It's a much better patient experience. I have aging and elderly relatives, and I've spent a lot of time as a service user of the NHS. Navigating the NHS estate is a bit of a nightmare at the best of times. These are big buildings built a long time ago, which sadly are now not fit for purpose. This is a state-of-the-art building. But this is the challenge they face, Neil. They have taken up existing space within a shopping centre, and they've made the CDC, the Community Diagnostic Centre, fit this space. But there is a challenge, because not all shopping centres will have 2 or 3 floors to give up. And to build CDCs from scratch takes time and money.
The announcement from the Prime Minister today, certainly not limited to CDCs. Digital, a big part of the government's plans for reforming the health service. Tell me a little bit about the app.
The focus is now on patient choice. The app will give patients as much information as they need to be able to make the choices they need. So they can move to 4 different NHS providers and 1 private healthcare provider. For too long, too many different parts of the NHS were not connected digitally. And that information was lost going from 1 provider to 1 service, from your primary care provider to your hospital. Now it is all in one place. The problem with that is everyone is going to have to be a little more tech savvy. And the challenge might be for what we know is already an aging population with complex comorbidities who are using the NHS more and more, and how they will navigate a digital NHS.
It is ambitious, isn't it, Ashish? 92% by 2029. I mean, fundamentally, the NHS is currently massively overstretched. So do you think that ambition is perhaps a little bit on the big side?
It's a huge ambition, but I think they need to set ambitious targets. Otherwise, if they try to do too little, you just won't make any sort of movement on that dial. And What they've done is they've gone for the electives because that is a metric that they can measure quite easily. There is a list, a really tangible targets that they know they can hit, and they know they should be able to achieve if they have the goodwill of the NHS staff on board. Remember, no extra money, no extra staffing. They have to do this within the existing resources and the money that's been earmarked for the NHS through the last budget. As long as, alongside it, they continue to train more staff and work on the recruitment and retaining the staff they already have.
In a moment, we'll continue to discuss if these plans are worth more than the paper they're written on with someone who's been studying NHS waiting lists for 3 decades. So, with the inevitability of arguments around the Christmas dinner table, every winter we find ourselves debating what to do with the NHS, usually because it finds itself in dire straits. And yes, the health service is currently in the middle of another winter crisis. But we also have fresh government plans to sort it out. Dr Rob Findlay is a specialist in NHS demand and capacity and certainly knows a thing or two about waiting lists. I mean, Rob, just how long have you been taking a look at this sort of data?
Yes, about 30 years, I'm afraid. I was in almost from the start, just after the NHS's very first elective waiting time target was achieved in 1992.
And what do you make of Sir Keir's plans?
Number one, reducing waiting times is clearly really, really important. It's a matter of quality of service, it's a matter of fairness, and it's a matter of patient safety as well. Secondly, there's a lot of emphasis in the plan on reducing outpatient and diagnostic waits first. The third thing that I think is really welcome, and which is a bit of a departure from previous guidance, is the amount of attention that there is to the nuts and bolts of the process. This is deeply unexciting and unsexy sort of stuff about how do digital messages get passed around the system, but it's really, really important, and there are tremendous gains to be made there. Then there are the buts. So how could it go wrong? Well, one way it could go wrong is that the elective care simply gets crowded out by other things like pressures on emergency care, ambulances and emergency patients in hospital. I'm not sure that the approach they're taking to the milestone targets is as wise as it could be. The goal that they're trying to reach in 2029 is to have 92% of the waiting list within 18 weeks. That's the statutory target and has been since 2012. There's a risk with the approach they have taken, which, let's take 65% within 18 weeks by March 2026. If you're a patient on a waiting list, how do you know how long you're going to wait? Are you in the 65% or not? Had they chosen the waiting time and gone from the current 42 weeks down to, pluck a number out of the air, 36 weeks or something, at least you'd know that you shouldn't be waiting longer than 36 weeks in that example.
Are you in essence saying that hospitals, trusts might prioritise interventions that are easier to do, that are cheaper to do, and they can do much more of just so they're hitting that target?
Yes, that's right. There are pros and cons to that. So the pros I've already outlined, which is that clearing out patients and diagnostics is really important to get patients to diagnostics. But the cons are that if you're a hospital, you might be thinking, well, some of the patients on my waiting list I can see and treat relatively easily, and others are going to need a lot of time on the operating table and time in a hospital bed, so hip and knee operations. And they might be thinking, well, if I do the easy cases and use them to do the 65% within 18 weeks, and then the expensive, difficult cases, that's where I'll pick up the slack on the 35% balance. There's a risk that the difficult cases get left until later. And then you've got a very difficult catch-up in the final years and months up to 2029 to try to clear the really most difficult part of the waiting list to get to the end result.
I'm detecting kind of pretty broad kind of acceptance of the plans that's been put forward by Sir Keir Starmer, but with some pretty significant caveats, Rob. But do we have, through these waiting list figures, an accurate view of how many people are, in inverted commas, waiting for something on the health service, be it surgery, be it diagnostics, be it just a face-to-face meeting with a flesh and blood human being to talk about themselves being ill?
The published figures don't give you a very granular view, and they're also incomplete. The hospital should have very comprehensive information about exactly who is waiting and exactly for what. So what's missing from the official NHS waiting list figures is a large number of patients who are delayed for what's called a planned appointment, for instance, follow-up outpatients. So there are very large numbers of patients in Britain who have a chronic health condition. Now, you're supposed to have a follow-up appointment. If you miss that appointment, you're at clinical risk because your condition might be progressing without anybody knowing about that or being able to remedy it. And the NHS rules for waiting lists say that you should start a waiting time clock the moment you're overdue. This rule is widely ignored, and I think after the passage of time, it's safe to say that NHS England are not enforcing the rule. Many trusts are unable even to count how many patients are in that position. Some are able to count them, and some have even published data on how many overdue follow-ups they think they've got. And in some cases, there are hospitals reporting that they've got more overdue follow-up patients than they do on their entire elective waiting list. Now, these figures, remember, they're meant to be included in the waiting list figures. They're not. So potentially there are millions of patients out there in the NHS who, because they're overdue for a follow-up appointment or another planned event, they should be on the waiting list, but they're not. Now, these are huge numbers. In the plan, they have commendably taken some steps to try to reduce the impact of this by giving patients more control over their follow-up care. But nevertheless, if the numbers are that large, it would be big enough to blow quite a serious hole in the achievability of restoring 18-week waits.
So in short, Rob, the problem is even worse than the official data tells us, and we don't actually know just how bad it is because no one has the complete data. Okay, so to put you on the spot then, what would you do? What's not in Sir Keir Starmer's plans that you would have liked to see?
I would like to see the follow-up outpatients and other delayed planned care patients brought out into the open so that they're visible and they can be managed safely, and the clinical risk caused by their delay can be reduced by getting them in. The concern I have about the way that the plan has been constructed at the moment is, although they're taking steps to mitigate that risk, it is not so far being done in an open and transparent way. But surely if what really matters here is the quality and safety of NHS care for patients, then this is an important part of it and it should be in the mix.
Rob, in your mind, is this the moment at which the long-standing and well-known problems within the health service start to be tackled? At the end of this Parliament, will we be looking back at this point and saying, do you know what, that's when Sir Keir Starmer started to get it right?
It's possible, and I hope so. We've done this before. The new Labour government 15 years ago reduced waiting times from over a year down to 18 weeks. To nearly 18 weeks on the current measure. The coalition government then consolidated that and got it down below 18 weeks. So we've done it before. The difference between then and now is that back then, Labour had the financial headroom to double the NHS budget in real terms while they were doing it. We don't have that luxury today. And as the saying goes, when you haven't got any money, you have to think. I think there are signs in the plan that they have thought. It is possible, but it's not easy. So there's going to be a lot of work. Will it succeed or not? At the moment, I don't think anybody can tell you. It's certainly not going to be easy, but it is possible, and I really hope it does work.
Dr Rob Findlay, great to have you with us. Thanks for your time.
Thank you.
And you can read our correspondent's analysis of the announcement on skynews.com. We're back again tomorrow.